Hello, everyone. This is Dr. Ahmed Al-Rajih. I'm an assistant professor at King Faisal University in the respiratory care department. So today we will talk briefly about acute respiratory failure and airway management. Um, so we will try to cover all these subjects, although it's really hard to speak about them with full details, but we will try to focus on the main things or the main procedures that we usually do in our clinical practice. So what is acute respiratory failure? Respiratory failure is a syndrome of inadequate gas exchange due to dysfunction of one or more essential component of the respiratory system. So what are these components? Of course, our respiratory system either give us oxygen or taking the carbon dioxide out of our body. And saying acute respiratory failure, that's mean we have a problem either in one of those, either the oxygenation or the carbon dioxide elimination. So if we want to classify them, we can say type 1 and type 2, and I'm sure that you heard about those two. So type 1 is known as hypoxemic, which means failure to provide adequate oxygen to meet the metabolic needs. What are the causes here? ARDS, pulmonary embolism, edema, septic shock, infection, inhalation, aspiration. It's too many things to be honest, and we will try to simplify it. We will go here to see the structure of respiratory, trying to understand the basics first. So if an individual takes a breath in, the air will come and travel all the way down here, and it will passes the trachea, the bronchial, the bronchioles, then until it reach the alveoli. Alveoli, I'm talking about here. Those are our alveoli, and this is where the gas exchange happening. If you can see here, the pulmonary capillaries surrounding the alveoli. So going back to this slide, so if the oxygen travels all the way down, reaches the alveoli, then diffuses to the pulmonary venules, uh, then the oxygen will travel to our body, and here the CO2 comes out and leave to the out of our body. So going back to type 1. So if we are saying type 1 failure to provide adequate oxygen, means here all what we have is intact. The main issue it's going to be probably in the alveoli. It might be filled with a fluid, and that fluid either it could be due to infection like pneumonia, water, for example, like CHF, edema, and blood. It could be from injury. And if we want to go back again and see what's type 2, type 2 is failure to eliminate CO2. What are the causes of the type 2? Uh, think about it here. So the first one, we said we have a problem with the alveoli. The air, the oxygen can naturally pass and diffuses here, and we have no problem with our airways, which means that we have a problem with the ventilation, but the perfusion, we have no problem. That means we will have a VQ mismatch. But with the type 2, we have no problem, most likely in the alveoli. We could have, but the main issue is with the airways. And this one we can see it, for example, with COPD patients, asthmatic patients, people or patients with diminished respiratory drive, for example, obese, patients, neurological disorders. Um, with those, you can take the air in, but you cannot take it out, which would cause or lead to CO2 retention. So what are the manifestations or clinical manifestations? Of course, hypoxemia, cyanosis, tachycardia, and here due to the patient is having accumulative fluid in his lungs, then he started to increase the work of breathing. He cannot really breathe properly. Then probably he will be stressed out. Then we will have a tachycardia here. His heart rate will increase. And if we are talking about people with chronic conditions like COPD and or asthma, we may start to notice the nasal flaring with them. Of course, we said we may see edema or CHF, and here it says lower extremities edema, and severe stages we could see central nervous system dysfunction. How could we manage it? Um, to manage a respiratory failure, we need first to treat the underlying cause. If it's a pneumonia, we need first to treat that infection. At the same time, we need to support the patient with oxygen to compensate something for him. In some cases, we need to give them non-invasive ventilation, put them in non-invasive, and in some cases or severe cases, we will go and intubate the patient and support them with the mechanical ventilation. So this is with the first bit, and here we will jump to the oxygen therapy. We see oxygen given almost to every patient in the clinic, right? But why actually we give it? We give it to maintain adequate tissue oxygenation while minimizing the cardiopulmonary work. Um, so as we said here, from the goal or the objective to maintain adequate tissue oxygenation, so the indication could be correct documented hypoxemia, decrease the symptoms associated with chronic hypoxemia, decrease the workload hypoxemia imposes on the cardiopulmonary system, or it could be given for short-term therapy. For example, when we give some bronchodilators, sometimes we use oxygen as well. So what are our contraindication? Uh, there is none or no absolute contraindication since we really used it for a purpose, but it can cause adverse reaction like atelectasis or oxygen toxicity. Um, when we say oxygen system, we just think about sometimes basic devices, but actually we can divide them into two different systems. The first one is the low flow system. The second is the high flow system. With the low flow system, uh, the main difference really with between the low and the high with the low, the amount of oxygen that we deliver to the patient wouldn't be fixed. Uh, where with the high flow system, it could be predictable. Um, here, Here, as you see, nasal cannula falls under the umbrella of low flow system, simple mask, partial rebreather mask, non-rebreather mask. I know a lot of people, they believe that this is could fall under the high flow, but actually no, it's under the low flow. What we need to look at here is the flow needed with each device. Uh, in order to deliver the desired FiO2. And as we said, with the low, it's varied and it's not fixed. Uh, but when we come to the high flow, the most well known around the healthcare practitioners is the Venturi mask. Uh, as you can set the oxygen or the FiO2 from 21 to 100%. Uh, Here, sorry. So here are some pictures. I know you are aware of these. So this is the Venturi. So people may not see that much, but we see it usually in the ICU. The nasal cannula, the one that we use always. People, by the way, sometimes they mix between the non-rebreather and the breather mask. Uh, how you distinguish between them? There is a valve actually between in one of them. How we monitor the oxygen uh, with the patients? Uh, we use pulse oximetry. In some cases, we do the blood gas analysis. So here, hazards and complications. As we mentioned earlier, oxygen toxicity and absorption atelectasis. Absorption atelectasis, we see it if we put the patient on more than 50% of FiO2 for a longer time, we may have this one as adverse reaction. And fire hazards. Why? Because oxygen, it's a flammable gas. Airway management. As we said in the beginning, we have a lot of procedures, but we are trying to focus on the main things and the things that we usually carry on in the clinic a lot. So why we provide the management is to maintain secured airway, patent airway, ensure adequate oxygenation, prevent aspiration. Do we have techniques and maneuvers? Yes. We have the airway maneuvers. We will start with it. It's a great and easy maneuver to apply. Uh, just extending the head slightly into the sniffing position and with the chin left. Um, but we have to be careful if we suspect that the patient is actually suffering or having any spine injury. If the patient actually does have or is it suspected uh, for injury, we could then apply the jaw thrust. Basic airway adjuncts. I know you are aware and you have seen these before. We use them to relieve the upper airway obstruction. We use it with unconscious individuals. You see them colored, right? So this color indicates the size. But should I go with the number or with the color? To be honest, the best way is to measure it. Uh, we have more than way to measure the proper size. One of them is the corner of the mouth to the air lobe. I think I have provided the picture here. Yes. So you see where is the tip is to the corner of the mouth, and this one, the end of it to the air lobe. So this one we could estimate the right size for the patient. When we come to inserting that, we have to insert it um, uh, upright. Uh, starting, I'm sorry. So starting from here, we will insert the oropharyngeal airway. And when we comes to this step, we want to rotate it, then place it. Okay, so upside down, then rotate. When you reach almost the middle, rotate it, then set it. The other one is nasopharyngeal. Uh, the difference between them, the first one, the oropharyngeal, we use it with unconscious individual, but with this one, we use it with conscious. It can be tolerated by the patient with intact gag reflex. The sizing, also this one have the sizes written on the side here, as you see, but also we measure it uh, almost with the same thing, but with the from the nose to the air loop, from the nose opening. Uh, don't forget, when we are trying to use this one, we need to apply lubricant because the patient, he's awake, he's conscious. So we want to make this one as easy as possible. Um, so we need to apply enough and proper lubrication uh, before we started. So this is for the basic airways. And when we come to the advanced airways, we are talking about here the main thing or the thing that we use sometimes in emergencies, the laryngeal mask airway. It's easy to place, um, easy to insert, no special equipment needed. Uh, and here, yes. So here also not forgetting of inflating the cuff with 10 to 15 ml to seal it. And this one is the most popular one when we are talking about advanced airways, which is the endotracheal tube, um, placed either nasally or orally. We see it more often in the oral. Um, we could use it in short-term airway protection or for mechanical ventilation if we want to place the patient on invasive. Uh, here, so we have a picture of the AT tube here. Uh, I think everyone is well known, well oriented about the AT tube. Um, but what we need to prepare really is the 10 cc syringe and lubrication as well, because we need to lubricate this area, trying not to harm the patient. In the same way, also in the same time, also applying 10 cc uh, of air to the cuff so we can fix it. We can, okay. The indication for the AT tube to relieve the upper airway obstruction, protect the airway, to facilitate suctioning, to facilitate mechanical ventilation. So some patients, when they come, although they are awake and well oriented, but maybe they will deteriorate, then they cannot really protect the airway. They don't have the ability to clean or clear the secretion. So they need a support, they need a help. So then we will decide to intubate them and support them. Uh, we usually trying really to avoid the invasive procedures, but sometimes if it comes to now I have to protect the patient, then I have to do it. So this is a summary. What should we prepare before we go ahead and intubate the patient? Usually in the hospital, you will see it all gathered in one kit. Uh, to highlight here that before using the laryngoscope or prepare it, please check the light. Uh, not to check the light in the last minute, uh, and also preparing um, the forceps to ease things as well. Uh, Pre-oxygenate the patient. It's important. Um, when we place the AT tube, the things that we need to do is escalation, uh, hearing the breath sounds, so auscultation, uh, looking at the chest movement, uh, the capnography, the CO2 detector, and the chest X-ray. If you are not familiar with the CO2 detector, it's basically when we intubate the patient, we will ambubag them, right? We will see the chest movement escalate. Uh, then we can place the CO2 detector and the color will change. And this is basically to confirm that uh, the tube is in the trachea, not in the esophagus. Sectioning. I think this is the last part here. So what's the purpose of sectioning? To maintain the airway patency. As we said, also intubating the patient or taking care of the airways. The purpose is really to maintain a patent airway. To reduce the work of breathing, to reduce the pulmonary infection. We have two techniques, the closed sectioning and the open sectioning. The open, the open sectioning is when the patient is most likely awake, when they have also, you see it when they have an oropharyngeal or nasopharyngeal. Um, we do the sectioning. With a closed sectioning, when the patient is placed on mechanical ventilation, we use the closed technique to minimize the infection. So here it's just a summary site of sectioning. We tried to summarize the procedure for you, the things, and I tried to highlight it only the things that uh, you could remember easily. So before we start the procedure, the sectioning procedure, either the patient he is placed on mechanical ventilation or no, we have to inform them because sometimes this one it's unpleasant procedure for the patient. So I have to really introduce myself, then tell them that I'm here to do a sectioning to remove the secretion from their airways. Wash your hands, adhere to standard precautions, place the patient on pulse oximeter because you want to see they may deteriorate very quickly. Set the vacuum at 100 to 120 for adults. I will talk about this one in a bit. And positioning the patient upright. Pre-oxygenate the patient with 100% O2 for 1 to 2 minutes. Put in sterile gloves. Okay. Sectioning via intermittent occlusion of the thumb. Also, while you are going out withdrawing the catheter, you can rotate as well. So you can collect or reach out as much as you can from that secretion. Uh, And when we go in, we try to not to stay in more than 15 seconds. So the things that we need to monitor is the breath sounds, the saturation, the respiratory rate and pattern, the hemodynamics, sputum characteristics. Is it colored or no? Is it thick or thin? Because it's matter. So we need also to document it, the amount and the color, and if it's thin or thick. The intracranial pressure, the ventilator parameters. If we are taking a blood sample from the patient after the suctioning, also we need to check the results. Here, things to remember: routine suction should be avoided. I saw in some areas where every time they pass by the patient and they know that he has secretion, they will just go ahead and do a sectioning procedure. And we always say try to avoid that. At least if you can do it one every 2 hours, uh, okay. Because especially if the patient is ventilated and you are taking off the circuit and placing the catheter, doing the sectioning, you are really affecting the patient by any means. Pre and post oxygenation for the patient. Please select the proper size of the catheter for the sectioning. The amount of negative pressure. Here we are talking about the vacuum. Sorry. Here we are talking about the vacuum. So for adults, you can set it between 100 to 150, children 100 to 120, infant 80 to 100, neonate 60 to 80. Again, this is briefly the procedure, uh, things that you need to highlight, pre-oxygenate the patient and inform them. So inform them, pre-oxygenate them for 1 to 2 minutes with 100% oxygen, intermittent while during the sectioning and while you are going out, you could rotate. Please don't stay more than 15 seconds. Um, and also the vacuum. Um, it is important as we saw with some practitioners. Sometimes they put 150 for an infant, uh, which is harmful really for the patients and could affect the patients. So that's all. Thank you so much.